الأخ الأستاذ دكتور سداد التميمي من ويلز في المملكة المتحدة. تفضل دكتور سداد.
شكرا جزيلا. في بداية الأمر كل عام وأنتم بخير، وإن شاء الله العام الحالي يكون عام بهجة وسرور للجميع. سأتحدث يعني معظم الوقت باللغة الإنجليزية، بس بعض الأحيان سأحاول قدر يعني جهدي أنه أستعمل اللغة العربية إن شاء الله. First of all, I mean, dissociative disorders. I mean, the topic of the lectures were determined by Dr. Walid, who I think rightly so asked us to think about introducing the ICD-11 classification and in our new lectures and talking about different subjects. And I have chosen dissociative disorders. I mean, the reason why I'm choosing dissociative disorders, because I have experience in these disorders, done some research, and this is actually didn't start with my career in psychiatry, but actually with neurology. Okay, and you might find today that some of the issues in the lecture, you might feel, oh, he's a little bit biased towards the neurological concepts. Okay, I mean, anybody who works in neurology and does some work in epilepsy will come across dissociative disorders. But the way they look at these disorders, the way they manage them, probably is slightly different from what we understand in psychiatry. But really, what are dissociative disorders to start with? Frankly, dissociative disorders in psychiatry is hysteria, okay? But nobody uses the word hysteria anymore, isn't it? I mean, it is basically hysteria. And hysteria, the concept of hysteria, if you really look at what it is and dissociative disorder, you can date it back to the Greek times. I mean, but then, I mean, people use the word hysteria probably at the time, as Dober said in 1733, to describe a woman, while the man used to be described as hypochondriacal. Then neurosis as a concept appeared also in the 18th century, okay, and hysteria was at the center of it. But then our neurological colleagues, I mean, really destroyed the concept of hysteria by the famous article of Slater in 1982, 1984, who thought that was really a very anti-feminine concept created by men. Okay, so that's what's really dissociative disorders. It probably has remained the same all over the years, from the time of the Greeks. Then we have the 17th, 18th, 19th century. Then we have the DSM-3, DSM-4, 5, and then we have now the ICD-11, and we look into details about the ICD-11 in a minute, okay? Right, so what I'm going to do today, the lecture is divided into 3 parts. The first part will focus on the dissociation as a concept. The second part will focus on the ICD-11. And the third part will focus on the neurological aspects of dissociation, or what is termed as FND, or functional neurological disorder, okay? So this is how the lecture will be divided. So I will, first of all, we will start looking at the concept of dissociation. Now, what is dissociation? I mean, dissociation is an ego defense mechanism, all right? Now, when we talk about ego defense mechanism, we talk about a process that is unconscious, okay? But as an operation would lead to symptom formation and responsible for character pathology. None of us is without a defense mechanism. We all use them. The psychoanalyst and the psychodynamic psychiatry look at the defense mechanism as a barometer of our psychological health. The more you use of mature defenses, the happier you are, the more mature you are. And then you go down to neurotic defenses, then you go down to immature defenses, and then you go down to psychotic defenses. Okay. So basically, it's an ego defense mechanism. Okay. Now, but where is it in the ego defense mechanism, dissociation? All right. Sometimes people forget about the dissociation as defense mechanism. They look at it as a psychological process. Okay. Now, if you look at the dissociation, you find it sits with other primitive defenses like splitting, denial, acting out, projective identification. Dissociation itself is a primitive. Somatization, schizoid fantasy, regression, idealization, projection. Now, if you look at all these clusters of primitive defenses, I think any one of you would say, well, I have seen all these defenses in the patient I treat for dissociative disorder, okay? And this is what you have to remember. It is a primitive defense, okay? Then the most important part for talking about dissociation is its relationship with splitting. I think any one of you, if you asked, will always link dissociation to dissociative disorders, while link splitting to borderline personality disorder, okay? And actually, you know, much of the research and understanding of what goes on in the dissociative disorder has emerged from studies of people with borderline personality disorder. And as you know, borderline personality has its history as well. However, as a concept, it started to emerge in the 1930s, while dissociation dates back to the 18th century. So how do you separate between the two? If you can separate between dissociation and splitting. Let's look at splitting. Splitting, it's simply you compartmentalizing experiences of the self and others so that that integration is not possible, okay? When you confront them with the contradiction in their behavior, thought, or affect, the patient would regard the differences with a blind denial or indifference. As a result, it prevents a conflict stemming from the incompatibility of the two polarized aspects of self and other. Now, that would fit in a patient with borderline personality disorder, isn't it? While if you look at the dissociation, the definition of it is disrupting one sense of continuity in the areas of identity, memory, consciousness, or perception as a way of retaining an illusion of psychological control in the face of helplessness and loss of control. In extreme cases, it would lead to alteration of memory of events because of disconnection of the self from the event. Now, that event could be real or imagined. Now, if you look at the two, actually, definition, they are not much different, okay? There is nobody is saying that we are pushing experiences into the unconscious, maybe in the field that we are unaware of, okay? So when you use dissociation, you refer to dissociative disorder. When you use splitting, which is not much different from dissociation, you are talking about borderline personality disorder. So dissociation is linked to dissociative disorder, unexplained symptoms in neurology, 1/3 of the patient who attend medical outpatient clinic. And of course, nowadays, it is linked to trauma, okay? Trauma now is the big issue in psychiatry, in psychology, post-traumatic stress disorder, everything we're trying to focus on some kind of a past trauma. Splitting, however, part of borderline traits, we look at it in personality disorder, but also it is linked to trauma. So I said, trauma is the big subject nowadays in mental health and in psychology as a whole. Okay. But there is another concept that in psychiatry, and this is dissociation and repression. You see, this is one of the things that you might encounter if you are asked by a judge in a court about somebody in a dissociative state. Like, for example, I mean, we had one day a Nigerian lady came to court. Whenever people try to interview her, she will change. She will start uttering words that you don't understand. She keep on moving her head from one side to the other. Okay. And then people would ask well, she goes from one presentation to the other. You can't get any sense out of her, and so on. Now, when the court asked, I mean, is that conscious or unconscious? What does she suffer from? The diagnosis was dissociative disorder. Now, but what is the difference between dissociation and repression? You see, repression, you push something into your unconscious. The people would say, well, there is a horizontal split. Now, with dissociation, there is nothing being sent into the unconscious. According to the definition, there is actually a vertical split, so people are aware of it. Now, the court might look at dissociative disorder completely differently, and they look at it, well, people are aware of what they are doing, okay? Now, psychiatrists might not agree with that, okay? But from a legal point of view, nobody has said that the dissociation is a horizontal split like repression. It's actually a vertical split. And this is one of the areas that you face sometimes when you talk about dissociation, and it's in court cases. Of course, they are quite common in the United States, okay? In Britain, they are not as common as you see in the United States of America, right? So this is really the concept of it, okay? That's the concept of it. It's a vertical split. It's not much difference from splitting, okay? And it's a primitive defense or a primitive process. Now, we have the DSM-5. We have been using it for almost 7 years or more, okay? And actually, the classification in DSM-5 is linked to depersonalization, derealization, dissociative identity disorder, and then they have the dissociative amnesia and not otherwise specified. It's a little bit simpler, okay? Not over-inclusive, and the whole focus seems to be, was on dissociative identity disorder, which takes the old concept of multiple personality and so on. So now, ICD-11 is over-inclusive, in my opinion. But what's good about it, it puts all the symptoms in medical, neurological, and psychiatric practice into this category of dissociative disorder. So how does it define it? If you look at, focus on the definition here, you'll find here it's involuntary disruption or discontinuity in the normal integration of the following: ID, sensation, perception, affect, thoughts, memory, control over body movement or behavior. It says involuntary, it doesn't say unconscious, okay? Then that disruption may be complete, but it added a very important point, which is it's more commonly partial. And I think that's a very intelligent addition, because this is really what happens in real life. And it varies from day to day or even from hour to hour, okay? And of course, it cannot be due to effects of medication or substances with withdrawal effect. You cannot explain it by another disorder, not accepted as cultural, religious, or spiritual practice, and sufficiently severe to result in significant impairment in personal, family, social, education, occupation, or other important areas of function. So what does that mean? That actually dissociative symptoms, okay, unless they result in significant impairment, they shouldn't be regarded as a mental disorder all the time. Okay. Now, the first category, which really relates to our colleagues in neurology, is the dissociative neurological symptom disorder. Okay. Now, it is also the presentation of motor, sensory, and cognitive that imply an involuntary discontinuity of normal integration of our motor, sensory, or cognitive function. That sits nicely with neurological practice, okay? And it is not consistent with recognized disease of the nervous system, other mental or behavioral disorder, other medical condition. It also excluded withdrawal effect or a sleep-wake disorder. Okay. But you find here the neurological symptom disorder, the visual, the auditory, vertigo, other sensory disturbance, non-epileptic seizures, speech, paresis, gait, cognitive, others. And actually you find it is the auditory hallucinations that bother us most. Most of the time when people complain about voices, a voice is telling me to do that, you find sometimes they put in their psychological session, you know, the number of voices, who are the voices telling them what, and so on. And they are in clear consciousness, they have full insight. Sometimes they send them towards the psychiatric practice. Of course, they are very anti-psychiatry. They end up then, being treated for psychosis and so on. Okay, but unfortunately, the prognosis of these symptoms is not as good as what people think. Okay, especially with non-epileptic seizures. Around 90% of them really do not achieve full time remission. Now, dissociative amnesia, okay, is the inability to recall important memories. Now, these memories are autobiographical, okay? So when you do a memory testing for them, okay, you remember 3 objects in 3 minutes and so on, or 5 objects, 5 minutes and so on. They're quite normal. You do all the memory tests, they are normal. Now, it is typically of recent traumatic or stressful event that is inconsistent with ordinary forgetting. Now, one thing about the definition is the question of recent traumatic or stressful event. Unfortunately, what you see in practice and what people stress on, especially on research on dissociative disorder, is childhood traumatic or stressful events, okay? And I will come to that later on when we discuss the trauma model, okay? Then we have trance disorders. Now, these trance disorders, they are not very clearly delineated in the DSM-5, while here the trance disorder is characterized by trance states. والدكتور وليد أخبرني بأنه trance state هي غيبة, in which there is a marked alteration in the individual state of consciousness or a loss of individual customary sense of personal identity. Now, the individual experiences a narrowing of awareness of immediate surrounding, unusually narrow, selective focusing on environmental stimuli, and so on. But the question you ask about this trance disorder, I mean, if you look at the definition, okay, loss of individual customary sense of personal identity, they go from one place to the other, but they always know where they come from. They always find their way back, okay? You find sometimes some people will start to question how much of that is really altered the state of consciousness, how much of that is really motivated by the individual to avoid conflict or to avoid persecution of some kind, or got himself into trouble, and so on. But then, also I found that quite an intelligent addition in the definition in the ICD-11. It states that the trance state is not characterized by the experience of being replaced by an alternate identity, okay? So that's because most of the time when you find those people ending up in a police station or in a train station, sitting on the platform of a train, doesn't know where he is, being picked up by the police or social services. Okay. Now they sometimes you ask them, who are you? Oh, I don't know. What is it? And you start to sense that this is not really trance state. They get diagnosed as trance state, but they are not. Okay. Now, also important, they have to be recurrent. And if the diagnosis is based on a single episode, the episode has lasted for at least several days. Now that definition actually would narrow the cases of trance-like state that being diagnosed in a practice, like somebody you pick up on a platform of a train station, or you pick up wandering around on the motorway on his own, and so on. Most of the time, you find those people have really suffer from a factitious disorder or Munchausen or some other psychopathology. Now, possession trance disorder is not much different, but here the patient is, his customary sense of personal identity is being replaced by external possessing identity. Okay. Now, you don't see much of it in the West, but probably you see a lot of it maybe in the Middle East or other Eastern cultures. Okay. Sometimes it is difficult to replace from malingering, okay, or some other kind of personality disorder. But at the end, you find also here the definition is very strict. Also, it has to say the episodes have to be recurrent, okay? And if it is based on single episodes, it has to last for at least several days. It is involuntary and not accepted as part of a collective cultural or religious practice. So here we come to what is good about the ICD-11, despite the fact that a lot of you look at the DSM-5, the definitions of a trance state and possession trance disorder, okay, is really very, very strict. And you cannot just diagnose somebody with trance-like state following an episode lasting an hour or two and so on. It has to be recurrent, not a single episode. And if there's a single episode, it has to last for at least several days. So we come to the most conflicting part of dissociative disorder. I think you all agree with me, and this is due to this issue with dissociative identity disorder. Now, in the ICD-11, dissociative identity disorder is characterized by disruption of identity in which there are two or more distinct, you see the word here, distinct personality states, dissociative identities, associated with marked discontinuities in the sense of self and agency. Then it adds that each personality state includes its own pattern of experiencing, perceiving, conceiving, and relating to self, the body, and the environment. Now, of course, people state, oh, it is different from the old concept, multiple personality. It's not really that much different in reality. Okay. Now, you find that in many pieces of literature. بالحقيقة إحسان عبد القدوس في أحد رواياته أحد متى أذكر الاسم مال الرواية أتصور بئر الحرمان اللي عملوه كفيلم في أتصور الثمانينيات أو السبعينيات لسعاد الفنانة الراحلة سعاد حسني. كان بئر الحرمان هو قصة لإحسان عبد القدوس يصور فيها Dissociative Identity Disorder. طبعا تلاحظها هاي في الروايات، لكن في واقع الأمر بالحقيقة لا تشاهد الكثير منها. Now, one of the things about the dissociative identity disorder and the ICD-11 He said at least the two distinct personality traits, okay, recurrently take executive control of the individual consciousness and functioning and interacting with others or with the environment. And the changes in personality are accompanied related in alteration, sensation, perception, affect, cognition. Also, typically, there are episodes of amnesia which may be severe. Now, that definition is quite difficult to apply in practice. And actually, what you see most of the time, and which is closer to the dissociative identity disorder that is explained in the DSM-5, it's the partial dissociative identity disorder. Okay, when you find these dissociative identities, okay, each personality state includes its own pattern, but one personality state is dominant, normally for daily life, intruded upon by one or more non-dominant personality state. So there isn't that full separation of the two identities, okay? No executive control of one over the other, but actually there is partial. Every now and then there is a dominant personality trait and there is a more non-dominant personality state. And this is as well, actually, we call them dissociative intrusions, okay? You find somebody at home is different from somebody when he is with his friends. Somebody at work is different from somebody who is in a different workplace, okay? However, these intrusions, okay, they can be cognitive, affective, perceptual, motor, behavioral, and experienced as interfering with the functioning of the dominant personality state are typically aversive. It's that when people don't like that part of his personality. Now, is that dissociation or is that a normal functioning? Is that something we all experience every now and then in real life? Somebody you find in one place is different from another. There is some degree of it in every person's life, in my opinion. But then we have the other thing in the ICD-11, and this is the depersonalization. Depersonalization is either you feel unreal or somebody around you unreal. And these are the most common disorders, but frankly, they are more commonly seen as symptoms. Symptoms that you encountered at least in 30 to 40% of patients who attend the psychiatric outpatient clinic. Others, you have Ganser syndrome or Ganser sometimes. There is Ganser syndrome, hysterical. There are so many terms that appear in the literature. And frankly, Ganser syndrome, as you all state, somebody in police custody most of the time, alleging that he is disoriented in time and place, invariably give approximate answers to questions. You ask him, what is today? Today, as we all know, is a Tuesday. He will say Tuesday, Monday. What year? 2022. He doesn't say 2023, and so on, okay? It's actually, in real life, it is more or less some form of malingering. Now, this is the ICD-11, and you could see that it's a little bit different from the DSM-5. In my opinion, it is more inclusive and it is written with more clarity than the DSM-5. Now, also included in it, you know, the neurasthenia, neurotic disorders, deprecated, and the dissociative disorders unspecified. Okay. Now, we come now to the subject, the part. Is dissociation fantasy or it is really the result of trauma? Now, this is a very conflicting subject, okay? It's ongoing debate about it. And actually, in real life, you do encounter it every now and then when somebody will discover that the reason, the way they are and so on, because they were victim of trauma in childhood. And I think also the introduction of post-traumatic stress disorder as a complex, as a concept, is widely distributed. Also, there is the issue about the complex PTSD, okay, and its relationship with the trauma and so on. Now, I will try to be as neutral as possible, just giving you the outline of this issue, okay. Each of you might have a different experience. My experience is really based on seeing patients with non-epileptic seizures in epilepsy clinic. I have done my research on them, okay, and I wouldn't say which one, is it fantasy or trauma. I think that's something we left to you. But there is a history to it, okay? The history is not something new, okay? The first one who talked about it was Charcot. I know everybody knows who is Charcot in psychiatry. It's part of the history of psychiatry. Now, there is a very famous hospital in Paris, La Salpêtrière, okay? And that was in 1860. He was a neurologist, okay? In the beginning, Charcot looked at those patients, unexplained symptoms, as a purely they have a neurological disease. But after years of practice, he decided, no, this is really nothing to do with a neurological disorder. This is simply psychological or post-traumatic factors, okay? So that was Charcot's view. Charcot passed away in, I think, 1893, and then he was replaced by Joseph Babinski, okay? Now, at that time, the concept of hysteria, of course, it started to dominate the psychiatric literature, neurological literature. Now, he viewed those people, the core feature of hysteria, in his opinion, if they are really susceptible to hypnosis, then they are hysterical, okay? All right? He never believed that really simply can be hypnotized with the magic of the psychoanalyst. And then he defined, dissociation as a product of suggestion and persuasion. So to him, really, there is control of the therapist over the patient. And to him, those OP patients of Charcot's were very highly suggestible, and that most of their hysterical symptoms are the artifactual production of the setting and social demands to perform. Now, that was quite a statement, but you find that dichotomy of Babinski versus Charcot still exists till today. And I can really enumerate a few reviews and papers published recently about still that ongoing debate about this subject. Then came Pierre Janet, also at the same hospital. No, he went back to the concept of Charcot and said, no, this is nothing to do, suggestibility and so on. This is, they are, what we see of those patients is due to, the trauma events, okay? And then he developed a conceptual and psychotherapeutic model whose basic elements are similar to the modern trauma model. So we refer to it as TM, okay? Now, this trauma model, okay, that you read about is nothing really new. It is from the time of Pierre Janet, okay? Then Sigmund Freud appeared on the scene, and he was very influenced by Charcot early on and by Janet. So Babinski was out of the way, okay? But then Freud renounced the idea that repressed memories of childhood sexual trauma caused hysteria. To him, no, these memories are due to audible fantasies. So you see, the concept when we talk about fantasy thinking came from Freudian. And actually, till now, the psychoanalytical school, psychodynamic psychiatry, doesn't really accept the trauma model that is quite popular in many places, okay, especially in psychological setting, okay. So that one, Freud, to him, no, this is nothing to do with sexual trauma. It is purely, these are memories to the audible fantasies. So the fantasy model that we talk about, the origin of it is Freudian, although most of the people who are critical of the trauma model are not psychoanalysts. A lot of them actually have nothing to do with psychiatry. A lot of them, they practice in neuropsychiatry. Some of them are neurologists and so on. Okay. Now, the psychodynamic school is silent about the issue because the trauma model is quite popular in the press, media, the among the patient, general public, and so on, right? So how it is the prevalence? Now we come now to the question of our prevalence of these dissociative disorder. I think everybody knows that depersonalization, derealization are so common, okay, that sometimes it's difficult to say, well, is it really part of a psychiatric symptomatology? Now, there's a quite wide variation. Now, look at the general population. You look at one study, it will tell you it is 0.3%. Then you go to another study, which will give you a figure of 18.3%. Now, then you look at the studies that looked at the clinical population. It means that patients who attend outpatient clinic, you find that the figures also, they vary widely from 12 to 40%, okay? There are numerous studies, okay? Then you find dissociative amnesia, okay? Now, frankly, if I ask any one of you, something really very memorable event, do you forget that? You won't, really, isn't it? It's real life. Highly memorable events are not readily forgotten, okay? But trauma, grief, somebody assaulting you, you being imprisoned, and so on. Now, these highly traumatic events are memorable. Now, the psychiatry, it seems the other way around. No, these events, traumatic, are not memorable. They are readily forgotten. It doesn't really make sense. So as a result, we look at what do we have in the literature about the prevalence? 0.2% in China. In Turkey, there are studies that told you less than 1%, another study more than 7%. Canada, 3%. Not many studies I could find about the prevalence. Okay, this is why I quoted also these 3 studies. Now, the age of it is 30 to 40, okay? And it affects both sexes, okay? Now, how valid is that diagnosis? What happened to a man in the age 35 for getting something very, very traumatic, like being sacked from work, okay, being disciplined at work, okay? Right. Now, depersonalization, lifetime prevalence is 26 to 74%, and it involves both sexes, okay? Now, this is also will bring the question is really, is depersonalization, derealization disorder is a psychiatric disorder or just really part of our normal daily functioning, okay? So the modern history about dissociation really started to be affected by famous literature, famous literature, famous movement. And I think one of them was the introduction of the concept of battered child syndrome in 1962. Don't want to go into details. Then the feminist movement appeared in 1970. Although, to be honest with you, Slater, okay, was influenced by that as well when he pushed dissociative disorder into the neurological field. Then, of course, PTSD appeared on the scene in 1980, and then the DSM-4 brought with it dissociative amnesia, dissociative fugue, dissociative identity disorder, and of course, the media picked on the issue of trauma and dissociation. And then there is the scales introduced. I think the most problematic one, in my opinion, is dissociative experience scale. Have anybody of you used it? Now, it's simply something from 0 to 100, and they ask you, well, do you experience that, and so on. You pick up something, and then you ask them questions, they self-report. Then a scale D, and then a clinician administered dissociative state scales. Okay. Now, these instruments probably also, when they were introduced, they were used in research, and probably when you see the figures of 50% people suffering from that and that disorder is due to the way how these scales are being administered in clinical research. Okay. So what are the theories of dissociation? I'll try and be quick. I mean, the time is going on. It's the trauma model and what we call the fantasy model. We don't call it fantasy model. No, you refer to it as the socio-cognitive model. Okay. Now, the trauma model will focus on the childhood history of trauma, the dissociation, defend against psychic pain, and dissociation wards off memories. So simply you have experiences, you push them into one compartment, now push them into that compartment. It doesn't say the unconscious, it's another compartment in your conscious mind so that you protect yourself from pain. Now, the socio-cognitive model, you find, there are references put down. These are two famous review articles arguing for and against, okay? The socio-cognitive model, no, look at it as that there are three main issues, with trauma and dissociation, mediators and moderator, dissident variables. So they think there are suggestive influences of media and culture, the coexisting morbidity, highly aversive event, and people are fantasy proneness. Fantasy proneness is something you witness in real life. I'll give you an example. Somebody attending, you find some young kids, they are very vulnerable and so on. They are taken on by some group, some of them are religious or non-religious. Then they enter into what they call counseling, and all of a sudden he will come up with the memory that I was really traumatized at the age of 1 or the age of 2 years and so on. Okay, so suggestibility play a role, negative emotionality, cognitive factor, sleep disruption, social factor. And of course, the self-reports, okay? Most of the time, these are in research, are self-reporting. Okay, and as I said to you, always people use the dissociative experience scale to measure the degree of dissociation. So have a look at the DES. I have used it in research myself, okay, and see what you make of it. Right. So what happened with all that argument taking place in psychiatry? You find that really neurologists have pushed dissociation into a new era called functional neurological disorder. Now, I will give you just a quick reminder of it, okay? And I'll try to be in the lecture in 5 minutes' time. So FND is defined as the presence of neurological symptoms, you could see here sensory, motor, and cognitive, that are not explained by identifiable neurological pathology. Okay? And actually, the sensory motor will cover a lot of the things we see, and the cognitive will cover our amnesia as well, sorry, amnesia. Also, the cognitive, you can say, it will cover also the changes in personality. So the etiology of it, there are predisposing factors: psychosocial adversity, physical illness, exposure to illness model, precipitating factors: injury, mental health symptoms, conflict, perpetuating factors: avoidance, belief, expectation, and social isolation. If you look at that model of our neurological colleague, it is quite elegant, okay, and non-controversial. Sometimes people, invent a model for its elegance and simplicity. This is what happened actually with the, the trauma model. Trauma model is quite easy, isn't it? Trauma, dissociation, compartmentalization of the event, and so on, and as a result, you suffer the symptoms. Okay, but actually, the FND etiology is less controversial. So the contemporary explanation in the functional neurological disorders, moving away from trauma-focused models that we use in psychiatry a lot, and the emphasis on the dysfunction of higher order cognitive process. Okay. So to them, I find the research findings, which are quite interesting. There, it shows there is attentional bias towards social emotions. There is disrupted behavioral anatomic responses, theory of the mind or mentalizing deficit, over-centralizing, baseline hyperarousal, altered autonomic responses, and discordance between subjective and objective responses during affective processing. This is the summary of the research finding on those patients in neurology. And the neuroimaging finding, you'll find it will yielded increased amygdala activity, heightened motor circuit activation, altered prefrontal engagement, and enhanced motor limbic circuit functional connectivity during affective processing. So there is a dysfunction, and you find the amygdala activity and the heightened motor circuit activation probably plays a major factor into the production of symptoms, and the altered prefrontal engagement might explain many of the phenomena that we see in dissociative identity disorder. So you find this is from Pick et al. In 2018, and you find here how these get affected. You find the amygdala here, hyperarousal, autonomic hyperactivity, hypervigilance, and host motoric influences, while you find in the dorsolateral prefrontal cortex, you have the cognitive control and emotion regulation deficit. So there's something wrong with the way the brain processes stimuli, sensory input. Okay. Then you have in the olfactory or the orbital frontal cortex, there is the altered value-based viscerosomatic processing, emotional regulation, and mentalizing. So everything to them is really created within the change in the circuitry of the brain. I won't go into many details. You might get bored if we go on into every one of them, the way they interact, but that will summarize all these complex connection, all right, between different factors: psychosocial adversity, the biological vulnerability. There are some genetic problem issues here. Then we have the altered emotional processing, the effective hyperarousal, heightened responsivity, and the impaired awareness, impaired cognitive control, and automatic activation of behavior, motor, and sensory processes. So these, they interact together to produce symptoms. I don't think they produce only the motor and sensory symptoms. I think they produce all dissociative symptoms one way or the other. Now, how do we manage those patients? Okay, the important issue is that you have to be careful about mixing the hyperarousal states of PTSD, okay, with the with dissociation, okay. The aims of it we know that dissociation is the failure of integration of emotion, cognition, memory, and somatic control, while treatment is an attempt to integrate emotion, cognition, memory, and somatic control. Now, if you manage to do that, it's good, okay? But really, it is easier said than practiced. Dissociative identity disorder always think of safety and crisis management. You treat comorbid mental disorder. If there is depression, treat depression. And anxiety, treat depression. Treat anxiety. Psychoeducation, supportive psychotherapy in different settings. There is no special psychotherapeutic model that you can apply to those patients, okay? Now, more commonly we see in psychiatric outpatient clinic is the depersonalization, derealization. If there is OCD, treat OCD. Depression, treat depression. Try not to let the patient drag you into the depersonalization, derealization, okay? Do not focus on treatment of it. Sometimes you have to tell them, look, at these symptoms, they tend to get better. And frankly, they do get better. 75% of them remit even without a treatment, okay? Now, most of the study of using medication to target depersonalized derealization are open and controlled study. I think lamotrigine is widely used, but actually the evidence for its usefulness is so limited and meaningless, frankly, okay? Then naltrexone, also uncontrolled trials. Psychotherapies. If you enter psychotherapy, try not to be dragged into explaining the dissociation and derealization. The patient will start talking about different planes, what he witnessed on the television, the way he identifies parts of his body, and so on. Now, try and focus on other events. Sometimes actually looking at the OCD model of psychotherapy might be more useful. Try and drag them into the issues of their thoughts or their intrusive thoughts. How do they tackle them, and so on. Okay, I think I will end here, and thank you very much for listening. Thank you.
Thank you. شكرا جزيلا دكتور سداد على هذه الرحلة السلسة في منطقة وعرة. أنا عندي استيضاحين عن علاقة الأوديتوري هالوسينيشن بالديسوشيتيف ديسوردر، وهل ترانس disorder is replacing fugue disorder?
Yes, yeah, that's what it does. It's replacing a fugue.
Yeah.
It's replacing a fugue disorder now.
And the point of the auditory hallucination, how does it relate to?
Right, yes. I mean, auditory hallucinations, as you all aware, I mean, auditory hallucination suddenly appeared in the ICD-11 as a neurological symptom. Actually, most of the research come from it is from patients with borderline personality disorder. Now, in borderline personality disorder, the focus is on pseudopsychotic symptoms. Some people say, no, they have a transient psychotic episode. But you find that sometimes the voices, the ICD-11, identify them as, auditory neurological symptom. I think it's quite an intelligent one. I mean, sometimes, because what happens sometimes is that you find that those patients are readily diagnosed as suffering from psychosis. But actually, they start to verbalize that, oh, I have like a voice hearing me and so on. And then they will be pushed into the psychiatric practice suffering from a psychotic episode. But actually, most of the research that came that have arisen came from the study of patients with borderline personality disorder, that we call them dissociative voices. But in ICD-11 is put under a neurological.
دكتور نزار تفضل.
مساء الخير على الجميع. شكرا دكتور سداد على المحاضرة الجميلة. طبعا يعني منطقة وحلة صعبة جدا، بس المحاضرة جميلة. عندي يمكن 2 أو 3 تعليقات أو أسئلة. The first one is really about the dissociative identity disorder. One of the problems with those people is when they go to court or when they are interviewed in the court, one personality tells something which is different from what the other personality tells. and this is a big problem for the judge and for the court. In fact, I have seen cases of double personality, not triple, not more than 2. And it was a bit difficult to deal with them. And even the mood was different between the 2 personalities. So that is one as a comment. But the question is related to the same subject. I don't know whether other than you, I'm sure you know Ali Al-Wardi. I don't know whether the rest of our colleagues know Al-Ustad Dr. Ali Al-Wardi, who spoke about Al-Shakhsiyya Al-Iraqiyya. It seems to me that it is a partial dissociated identity disorder. As you correctly said, the individual behaves in a way at home and completely different somewhere else. So it seems to me that Ustad Dr. Ali Al-Wardi knew about this concept, although he didn't label it as a multiple personality disorder or dissociative identity disorder. He called it a Shakhsiyya Al-Iraqiyya. But I think it could be applied as a Shakhsiyya Sharqiyya also, not only Al-Iraqiyya. That is one question. The second question is, just like Dr. Walid said, that fugue disorder became trance disorder. What happened to conversion disorder in this classification?
Conversion disorder have disappeared. You see, I mean, it is put, if you look at the ICD-11 synonym, conversion disorder, but actually it has gone, you know. I mean, nobody is using the conversion disorder. They are all lumped into dissociation.
But the word hysteria came back in some of your slides.
Yes, well, because to be frank with you, I mean, the reason we don't use hysteria because it's not acceptable. But otherwise, the concept is remained the same, isn't it? I mean, as I said, I mean, it is the word hysteria, okay? It is not acceptable to use it, all right? You can't, so you say nowadays, you don't say somebody is hysterical, you say well, somebody is dissociative, okay?
Yeah.
But actually the word hysteria, I mean, it is, I think, the influence of Slater and the feminist movement, of course, has, but really the same concept of hysteria that the French talked about, Charcot, Babinski, and Janet, and Freud, is the concept that we nowadays call the dissociation.
The final comment is about the
نفس الموضوع بأنه هو الواضح في كوني أنا في ICD-11 صار لي سنوات معهم بأنه what we used to call dissociative versus conversion التغى الconversion صار motor dissociation.
Yes.
ايش صار مع السوماتوفورم ديسوردرز كيف موجوده في ICD-11؟
I think they have a separate concept, isn't it? If I am correct, I mean, the somatoform disorder.
Dissociation.
Yeah. Okay. My final comment was about the only part that links us with our neurologists is the functional non-epileptic seizures, which you beautifully really explained very well in your slides. They regard it as, I mean, they tell them that you have nothing. And in fact, they have a lot of things, as appeared in your last couple of slides. So instead of sending them away, the neurologists, I think they should be decent enough to send them to us so that we will deal with these cases. And it's one of the really big issues, this kind of functional non-neurological seizures. And really, you beautifully explained it, and thank you very much.
Yeah, you see, but non-epileptic seizures are the most challenging of all dissociative disorder. And actually, if you work in an epilepsy clinic, you will find 20% of treatment-resistant cases have non-epileptic seizure, but they have the worst prognosis. 90% of them never remit.
Yes, and some of them have both of them, Dr. Sudad. Some of them
both epilepsy
actual epilepsy and functional non-epileptic seizures.
And the problem is that when you send them to the psychiatrist, they really get offended. يعني يضايقون إنه يقول ما تروح يقول لك أنا مجنون بعثني إلى السايكايترست.
Yeah.
Thank you.
دكتور مروان.
أنا تمتعت جدا في المحاضرة.
شكرا جزيلا.
جدا مرتبة عميقة شاملة بكل المعاني. اضطراب الديسوشيشن أنا انطباع إنه من أكثر الاضطرابات الغير مفهومة والغير منتبه إلها واللي بيعانوا منها بتحملوا diagnosis misdiagnosis يعني على طول الوقت. يعني التوضيح هذا الديسوردر شيء كتير مهم لكل المهنيين. فشكرا على المحاضرة. انت بديت قلت يعني بحق انه هو ديفنس ميكانيزم، بس انا بدي اشير لانه ديسوشيشن هو كمان ممكن يكون نورمال ستيت، وانا رايي الشخصي نورمال ستيت بمعنى انه الوعي تبعنا غير قادر انه يشمل كل جوانب تجربتنا. يعني إن نكون على اتصال مع ذاكرتنا ومشاعرنا وسلوكنا وهويتنا وماضينا وحاضرنا يعني تجربتنا كتير واسعة لدرجة إنه الكوجنيشن تبعنا لا يتسع. فالفرق الوحيد اللي أنا بشوفه بين الديسوردرز وبين النورمال سيتنج أو نورمال ديسوشيشن هو ما يسمى الامنستيك بارير، إنه في بارير تمنع اللي عنده ديسوردر to access and control يعني الأجزاء اللي فالتي من الوعي، بينما إحنا اللي عنده normal dissociation قادر إنه to access الإشي اللي فلت منه to control it ويرجع. هذا الفرق الأساسي اللي أنا بشوفه بين disorders وبين dissociation العادي. الأمر الثاني بخصوص الفانكشنال نيورولوجيكال ديسوردر، انا بعتقد كل ديسوردر سايكولوجيكال ديسوردر في له فانكشنال نيورولوجيكال ديسوردر. يعني الشيء اللي انت وصفته دماغيا لحاله الديسوشيشن اكيد للانكزايتي في شيء مشابه، للديبرشن في شيء مشابه، للسكيزوفرينيا في شيء مشابه. فدائما في الوجه العصبي للاضطراب النفسي اللي احنا نوصفه بشكل سلوكي او عاطفي. بخصوص النقاش هل الديسوشيشن او بالذات تعدد الهويات هل هي حقيقة ولا خيال؟ انا انطباعي ومن تجربتي بفكر انه اللي اشتغل ككلينيشن بيشوف انه هذا حقيقة، اما اغلب الادعاءات انه هذا يعني خيال هي جاي من الريسيرشرز اللي بحثوا تراوما وبحثوا ميموريز وبحثوا كيف ممكن تمانيبوليت ميموريز وكذا، فهن مقتنعين انه هذا يعني اختراع. ولحد ما انا بشوف كمان في مع انه هن متناقضين كوجهتين نظر، بس انا بعتقد انه يعني في ممكن نجسر بيناتهم. باي معنى؟ انا بفكر اي سايكوثيرابي هو بفكك وبركب. اي سايكوثيرابي بفكك وبركب اجزاء، إن كان الماضي والحاضر أو الجزء الغاضب اللي فينا أو الجزء المحب اللي فينا أو الجزء الضعيف والجزء لما بنبدأ نفكك ممكن تنشأ يعني تسميات معينة.
صحيح.
التسميات يعني هدفها التفكيك من أجل التركيب. هذا اللي مرر يعني صدمات متعددة وشخصيته مفككة كتير، فخلال العلاج أكيد بيكون في تفكيك، انه بنحكي عن ايدنتيتي معين وايدنتيتي ثاني عشان تتركب. فهي يعني حقيقه وخيال في نفس الوقت. يعني خلال الثيرابي ممكن الواحد يفكك وينشئ وكانه ايدنتيتي جديده، بس هي هدفها بالاخر عشان نركب. بخصوص الاوديتوري هالوسينيشن، كيف انا بعرفه من تجربتي، اللي بيميز الديسوشيشن اللي عنده اوديتوري هالوسينيشن هو انه بيسمع من راسه مش من برا، مش من كيانات خارجيه. هذا واحد من الاشياء اللي هيك بتميز بين الحالتين. انت بتقول انه الصدمات او الاحداث الصعبه صعب تنتسى. انا عرضت حالي قبل مده، حالي اللي عندها تعدد هويات، واللي كانت ناسي وفاقد الذاكره تماما على انه هي خلفت وعندها مولود، وخلال العلاج 4-5 سنين اكتشفت انه في عندها ولد صار عمره 15 سنه. فممكن يكون في نسيان لحقائق يعني هالقد مهمه في حياه البني ادم. الشيء اللي ذكرته دكتور نزار على انه بالمحكمه نفس الحالة هاي صارت نفي بالعلاج، يعني هي رتبت جلسة معي واجت، ولما طلعت شخصية تانية بتقول لي أنا بديش أدفع، أنا ما رتبتش الجلسة. شكرا لك. كمان سؤال يعني بتقدروا تشوفوا شبه بين الديسوشيشن وبين يعني نعتبر الديسوشيشن كأنه سيلف هيبنوسيس؟
I think so. I think يعني مثل ما قلت بالحقيقة بعض الأحيان الديسوشيشن يعني فتح الإنسان يستعملها كنوع من الاسترخاء، نوع من السيلف هيبنوسيس. يعني أريد أنفصل عن الواقع. يعني واحد مثل ما نقول إنه ينسحب، يحاول إنه يسترجع كيانه وكذا. فلذلك الإنسان يعني بعض الأحيان مثل ما تفضلت بصورة واضحة إنه هذا بالحقيقة بعض الأحيان عملية طبيعية يعملها الإنسان، وهو بالحقيقة بمن تلاحظ التعريف ماله هناك التعريف السلف هيبنوسيس لا يختلف كثيرا عن الديسوشيشن بالحقيقة أول ما نمارسه احنا.
أي سؤال أخير من الحضور؟ تمام، شكرا جزيلا. تفضلي بان.
السلام عليكم دكتور.
وعليكم السلام.
شكرا دكتور وليد، شكرا دكتور سداد. عفوا عندي سؤال بخصوص انه البيشنت المعتبرين depersonalization هم بالتصنيف معتبرين depersonalization derealization disorder يعني كانتيتي بوحده، بس احنا بالكلينيكال انا ما شفت بيشنت عنده بس depersonalization derealization كانتيتي بوحده، دائما comorbidity وياها.
صحيح صحيح.
يعني اما psychotic يا اما schizoaffective or any history. When taking the history the patient always have comorbidity. فبهيك حالة هم ليش معتبرينه كديسوردر بوحدة؟ يعني اكو patient يجي بس كentity depersonalization derealization، لو احنا هاي بس مجرد انه شو اسمه بالتصنيف.
صحيح، يعني هذا هو بالحقيقة يعني هذا الكونسبت. يعني مثل ما تفضلتي حضرتك ما تشوف ما يعني مريض انه يجي فقط عنده depersonalization derealization، دائما اكو في شيء اخر. بس هذا يعود تاريخه اذا ما اتذكر ظهرت في البيبر بالثمانينيات ل 44 حاله او بالسبعينيات 44 حاله تم وصفها في بيبر معين انه عندهم دول كان بيور depersonalization، كانوا كلهم نساء. تحدث انه هذا لم يكن عندهم اي اعراض اخرى. في الحقيقه معظم الاحيان السبب انه ماكو اعراض اخرى، انه المريض لا يقبل ان يناقش الاعراض الاخرى. يعني يحاول انه يركز فقط على التفارق زين والديريلايزيشن، يرفض انه يتحدث معها في اعراض اخرى. لا انا ما عندي اي شيء اخر. فهذا هو السبب بالحقيقه. كما ما تفضلتي حضرتك دائما اكو اضطراب اخر معه.
يعني انا اوضح لك مش منظمه الصحه العالميه عاده تاخذ باعتبار المناطق المختلفه. لو اعطيتك مثال على دول شمال افريقيا زي المغرب، الجزائر، تونس، لتشخيص اضطراب الآنية، هذا التشخيص يعني يتربع التشخيصات. تقريبا 70% من المرضى اللي يبعثوا لي استفسارات من هذه الدول يقولوا أنهم يعانوا من اضطراب الآنية. وعند الوصف يعني واضح من الوصف إنه بغض النظر إذا عندهم اضطرابات panic disorder أو anxiety أو غيره، التقط فقط Depersonalization يعني تقريبا يعني أسأل يوميا ما هو علاج اضطراب الآنية، وعندما تطلب منهم مزيد من التوضيح تجد أنه عنده anxiety وعنده depression وعنده panic وعنده 20 عرض آخر، لكن غريبة اختزلت إلى فكرة واحدة، اضطراب الآنية.
نعم. شكرا جزيلا دكتور وليد. شكرا جزيلا دكتور.
ما سمعتش دكتور وليد إيش أفضل علاج لاضطراب الآنية؟
يعني هذا سؤال صعب، لأن ما في أفضل علاج اضطراب الآنية، وتشخيص اضطراب الآنية وكأنه يعني الترند ماشي في هذه أكثر ما هو تشخيص فعلي. يعني في كل الحالات لا أحد منهم اتضح بأنه يتكلم عن Depersonalization syndrome. أكثرهم يتحدثوا عن شيء يعني مثل اللي نشوفه يوميا، يعني في Depersonalization Derealization لكن ضمن يعني other psychiatric disorder، لكن في تركيز مبالغ فيه لا أعرف سببه. ومع أني سألت الزملاء في الجزائر وسألت من يعني بالمغرب وفي تونس، وكانت الإجابة نعم، أن هذا تشخيص مرغوب ومحبوب لدى الناس ومحبوب لدى الأطباء. شيء يعني غريب، وهذا محبوب وبعدين يقولوا لهم ما له علاج. يعني هذا اضطراب آنية وبعدين هذا علاجه صعب وشبه مستحيل. في يعني comment in a movie split, one personality has diabetes mellitus while the other personality doesn't have that. Could this be true in real life?
No.
Of course not. يعني it's
only in the movies. Only in the movies.
In the movies, yes, but outside, no. الدكتورة صفية تقول إن الميديا ممكن لها تأثير على تشخيص اضطراب الآنية. صحيح لها تأثير، يعني لو أنا كتبت بس كلمة اضطراب الآنية هلاقي عليها 500 كومنت من المغرب العربي بس، مش ومن المشرق العربي الكل يسأل يعني شو اضطراب الآنية. هل ممكن المريض يؤذي نفسه أو ينتحر في اضطراب التعدد الشخصية؟
كلا، هذا أحد أنه نادرا ما يكون الإنسان يؤذي نفسه في يعني عندما dissociate from one identity to the other. Self-harm behavior is remarkably not recorded.
بس ممكن يكون self mutilation.
self mutilation طبعا أي هذا يعني إذا كان borderline personality، بس most of the time in a pure dissociative identity disorder it's remarkable that they don't have themselves.
على الديابيتس بس للتوسيع اللي قلته الدكتور وليد، ممكن يكون عوارض جسدية تانية تظهر عند شخصية وما تظهرش عند التاني، مثلا ضغط دم أو قصر نظر أو طول نظر أو أشياء من هذا النوع اللي ممكن يكون في فوارق في الفانكشن الجسدي بحسب الشخصية تبعت الشخص.
والله صعب، يعني ما في أي منطق طبي يفسر إنه واحد يكون يتغير ضغطه أو عوارض في العين أو في الرئة مع تغير الشخصية. ممكن إنها تزداد في يعني حدة في شخصية عن أخرى، بس لابد أن تكون موجودة.
لا ناخذ الحالات بدش الديسوشيشن، حالات عاديه، يعني الشخص اللي موجود في لحظه ستريس ضغطه ممكن يتغير. يعني هي لما بنتقل من شخصيه لشخصيه، ممكن ننتقل من شخصيه اللي خايفه كثير فضغطها بيرتفع ترجع لشخصيه هادي او ديبريسد، ممكن الضغط يتغير، فالضغط بتروح زي ما بتروح في الحالات العاديه.
صحيح، يعني في المؤشرات الحيويه نعم ممكن تتغير المؤشرات الحيويه مع تغير الشخصيات، لكن لا تتغير الامراض العضويه.
صحيح صحيح.
تمام، شكرا جزيلا دكتور سداد على
جزيلا،
الرائعة، وشكرا للأساتذة الكرام على النقاش المفيد. أنا الحقيقة تعلمت الكثير، وأمل أن يكون الحضور قد استفادوا أيضا.
شكرا جزيلا على دعوتكم، شكرا، يا مال الله.
الثلاثاء القادم تصبحون على خير.
صباح الخير.